Okay. Mute Godum. Hello? Hello, Ada? Hello?
Yes, I can hear you.
Okay, now, okay, so something like pin near my own screen.
There's no pin on your screen, just your voice.
Kevin, I put it in my screen. Kevin, I put it on my screen.
Your name and then voice indication.
Apart from, anyway, you can say for my something like my screen, you pin something. You pin my own screen to your monitor, the monitor.
I've seen it.
Yeah?
I've seen it.
You've seen it, ba?
Yes.
So now what you okay but type in what you okay to the monitor so that can I put also to work. I gonna so that's YouTube I gonna put you working at YouTube. What up?
Let me
No, look all the time.
see you. I've seen it now.
Yeah?
I just finished it now.
Okay, yes, if you go more now, then on pin is there more.
I've done that.
Okay, so there now. What are there now? Okay.
Yeah,
So be a pin which you working on better. Once I join the call, pin here.
no problem.
Thank you.
Good evening, everyone. My name is Kigozie. I am just trying to see if I can make a quick test run before we start. I might also just put my camera just for the next few seconds and just make sure that all is working well. Okay.
Okay, good evening.
Good evening.
Welcome.
Thank you.
Good evening, Doc.
Good evening, everyone.
You're looking very fine. No?
Let's not go into that topic.
Wow. Well done.
Thank you. I've been trying to share my screen, but for some reason it's not coming up. So I might just need to.
Maybe you can help share too. That was what.
Okay.
Okay, it's coming on.
I was trying to see if I can share the slide myself directly, but it's not letting me. So let's see if this works. Is it showing the slides now?
We can see your screen, not the slide yet.
Okay, that's the problem. Yeah, just give me 1 second. Let me try something else. Okay. I am ready to start though. If Dio can share the screen, that will make
Okay, give me a minute. Let me share the screen for you, sir.
thank you.
Okay, welcome everyone. Let's just wait for the slide to be shared, then we can start. Welcome. Thank you.
Okay, I can now share my slide. I've seen it. Can you see it?
Yes.
Okay.
Can you put it on slideshow, please, so that it will be bigger?
I think this is the problem though, because the last time I tried it, I couldn't work it on. Is it bigger now? Is it big enough?
I think it's fine.
Okay.
It's fine.
So good evening, everyone.
I guess we can. I guess we can start. So I'm the moderator for today. So we are going to start. I hope everyone can hear me.
Yes.
Yes, ma, we can hear you.
Okay.
Yes.
Good evening,
We
everyone.
can hear you.
I sincerely welcome all of us to today's monthly meeting. I appreciate your attendance. So today's topic, we are looking at respiratory muscle training. And our presenter is Dr. Chigozie Uchenwoke. He's a cardiopulmonary and critical care physiotherapist. He was a senior lecturer in University of Nigeria, Enugu campus. Currently, he's practicing in UK. So we're privileged to have him. The beautiful thing with this group is that there is a massive flow of knowledge in and out. So our colleagues that are in diaspora have been very kind in sharing their experiences, outside there, so that we that are practicing here, the students, the interns that are coming up, will have so much knowledge on how to handle patients, especially the current trends of patient management. So we welcome you, Dr. Uchenwoke. Is a friend, and I can attest to his love for cardiopulmonary. So, sir, the floor is yours now. Thank you. I wish us a good that we enjoy the presentation. Thank you very much.
Thank you very much for the warm welcome. I do appreciate. A good evening once again to every one of us that has made that time to join this teaching. It's an opportunity for us to share knowledge on our experiences so far. One of the things you would often hear me say is current reality is against our immediate or the expectations. So I will go with current realities against our expectations. So a lot of things I would mention in this conversation, especially on the practicalities, would deal around the expectations. And we would now have a look at what we are doing currently and what we could possibly do better in the future. I will just be talking about respiratory muscle training. So my job this evening is to be a physiotherapist and talk like a physiotherapist, breathe like a physiotherapist, and just do everything like a physiotherapist, basically. And this platform has enabled us an opportunity to meet this evening. From my point of view, we will be talking about just making a brief introduction of what respiratory muscle training involves, talk about just a mention of the anatomy and physiology, control of respiration, principles of respiratory muscle training, respiratory muscle testing, and then we will now go to the actual training itself, what we can do in terms of what is available in the literature as being effective against our current realities, the things we can actually do, adapt to actually make inroads to supporting our patients. For the want of time, I will just go quickly to my introduction. First of all, it's important for us to know that respiratory muscle training involves specific exercises. It could be different form of adjustments or adaptations that requires either inspiration, expiration, or both to stimulate the respiratory muscles. I often will say to some of my younger colleagues that the best therapy session is one that considers everything around the patient, not just their past medical history, but uses a variety of tools to actually support patient care. But we'll get to that shortly. Respiratory muscle training is aimed at individuals with asthma, COPD, bronchitis, emphysema, and neuromuscular diseases like myasthenia gravis, motor neuron diseases, Guillain-Barré syndrome, and your typical Duchenne muscular dystrophy. Now, other individuals that may benefit from the use of respiratory muscle training are patients with CVA and also patients with spinal cord injury. Now, there has been a question mark around the effectiveness of respiratory muscle training in weaning patients from mechanical ventilation. And this is often when the patient is utilizing it on currently tubed via tracheostomy tube. So it means that we can definitely be able to wean patients from mechanical ventilators if they are receiving or managing their airways through the tracheostomy tube. This essentially means they are not heavily sedated. They're able to engage in rehabs. They're able to do exercises by the bedside, even get out into the chair, do things like walk or stuff like that while still being on mechanical ventilation. Now, respiratory muscle training is targeted at improving the strength, and not just the strength, but also the endurance of respiratory muscle. And the goal of the respiratory muscle training is to increase ventilator capacity of the patient and also to decrease shortness of breath for the patient or dyspnea for the patient. And throughout this session, you will hear a lot of conversation around diaphragm and its effect, but it's important to understand why that is the case. Diaphragm is one of the major muscles of respiration, actually the major muscle of inspiration. And the diaphragm is, apart from the diaphragm, you have other inspiratory muscles like external intercostals. You have the scalene, the sternocleidomastoid muscles that are used mainly for inspiration. Now, respiration as it is, as a full-blown concept, is made up of the two cycles, inspiration, expiration. So respiration is not complete if there is no expiration, basically. So we'll talk about beats that revolve around inspiration and also talk about beats that revolve around expiration. Now, the first thing for us to note, The diaphragm is supplied by the phrenic nerve, which originates from cervical and brachial plexus, mainly from the roots of C4, but also you get supplies from C3 and also supplies from C5. And now this is the major reason why most of your patients with spinal cord injury at the level of C3 or C4 may most likely come down with phrenic nerve palsy. And this means respiration is impaired. Patient will most likely be ventilator dependent for a good amount of time, or if not the rest of their lives. So it's a common phrenic nerve palsy is a common injury that we found from some thoracic and cardiac surgeries. And also you can find a bit of phrenic nerve palsy from blunt of penetrating trauma, metabolic diseases like diabetes, infectious diseases like Lyme disease or herpes zoster. And you can also find it from neurological diseases such as cervical spondylosis, and then multiple sclerosis, myopathy, and immunological diseases like Guillain-Barré syndrome. So there's a whole lot of phrenic nerve involvement in this conversation. Now, spinal cord injury above the level of C3 will heavily impact on breathing, with nerve impulses being either completely disrupted or partially disrupted. Now, I wouldn't go into the details of levels of nerve injury that we may potentially have, the neuroplaxias and so on, because of the want of time. So I want us to flow very quickly and get into the bits of respiratory muscle as it is. Now for the accessory muscles, or basically anatomy of respiration, we have the principal muscle of inspiration, which is the diaphragm and the external intercostal muscles. If you're looking at the chest X-ray of a patient with COPD, one of the things you will find is that there is flattening and elevation of the diaphragm. If you're looking at the chest X-ray of a patient with COPD, it's typical, and it's one of the most typical things you can find about about the diaphragm on a chest X-ray. Now, the other things you can find is if costophrenic angle is blunted as a result of pleural infusion or things like that. But diaphragm is very heavily involved in the physiology and anatomy of respiration. It's so important to us. It's the major muscle of inspiration. And then we have other muscles of inspiration like external intercostals. And I've mentioned earlier about the scalene, the sternocleidomastoid, and there is involvement of pectoralis minor and some involvement of the major also to be able to produce inspiration. Now, what we often tend to do, or we often forget to do as physios, is that we forget to eliminate the input of accessory muscles when we are teaching breathing exercises. We allow our patients to actually utilize the accessory muscles for breathing exercises rather than just try to eliminate the influence of the accessory muscles and specifically negotiate around diaphragm, which is what needs to actually get enough emphasis. And this is what this teaching is about, basically. So we're going to go away from this teaching, being able to educate patients better on how to do proper breathing exercises that are targeted at actually getting results and not just strengthening the accessory muscles. A lot of times, what we do is to go in and have all that, take a nice big breath, or do things like take a slow breath in through your nose and stuff like that. At the end of the day, we're not eliminating the influence of the sternocleidomastoid, which sometimes becomes so elevated in the conversation rather than focusing on the diaphragm. Now, if we go to the next cycle, which is expiration, this is quiet breathing. Expiration results from passive elastic recoil of the lungs and the rib cage and diaphragm. Now, there is what we call active breathing. For active breathing, you need the involvement of the internal intercostals and the abdominal muscles to actually be able to pull off expiration. Can you see the next slide? I've gone to anatomy ongoing. Can you see it? Anybody?
Yes, we can see it.
Okay, so very quickly, I will just talk about how everything else connects to us. I've got a couple of things starting from the sinuses up here, and also thinking about how the upper respiratory tract deals with respiration going from the nose, the pharynx, the larynx, and then go down to the trachea, and then we have the main bronchi, and then the bifurcation of the bronchi, and where we have the lungs, the right and the left. Now, beneath the lungs is where you find the diaphragm, and diaphragm basically is dome-shaped. So it's important for us to understand that all of these structures above the diaphragm play an active role in what we're going to be discussing tonight. And while I was preparing this note, he made me realize that a lot of times we're often channeling our attention towards doing breathing exercises for obviously our patients who are awake, our patients who are maintaining their own airway, our patients who have a very patent airway and can engage and alert who are teaching breathing exercises. Now, we haven't thought about how do we help the patients who cannot do all of this because they are still very much heavily sedated, or sometimes on very heavy paralyzers like the rocuronium. And I've seen from experience that we can potentially alter IE ratio. This is basically inspiration-expiration ratio, which physiologically should stay at 1:2. Now, for several reasons, either hyperventilation or hypoventilation, you can have this ratio decreased or increased, as the case may be. Now, we can also alter the apnea time on the ventilator. I've got, in the last few years, or last 2 years, I've been mostly using the Marquette ventilator. So I fiddle around a lot with some of these bits just to help me understand, or to help the patients who are even very much ventilated to be able to do a couple of movements to the diaphragm. Now, all of this is targeted towards the diaphragm. And we can also change the end expiration time basically on our ventilators out here. It might be that you have a different form of ventilator. Imagine we have Hamiltons in Nigeria, a couple of places, and a couple of different other ventilators out there. They have slight differences, but if you study well around the ventilator, you'll be able to find what you're looking for in terms of how you're going to be able to manipulate some numbers to be able to support your patients that are ventilated. Now, going forward, because of time, the control of respiration is actually very important to us because it's something that happens from the central neural control and goes all the way down to the respiratory muscles and the lungs, which is what we're discussing this evening. We'll have implications of the upper airway, involvement of the external intercostal, the abdominal muscles, the lungs, as the case may be. Now, all of this shows us a massive connection of how we actually come about our inspiration and our expiration. Now, I don't want to go into the process of respiration because I believe we would have thought about how respiration involves bringing in oxygen and just expelling CO2 basically. And this is crucial for respiratory muscle training, is crucial for gas exchange. So the control of respiration happens at the upper centers. There's lots of connections that I won't really go into details with, but it will help if you can scroll through some of these, and the impact of these receptors on respiration actually would be quite helpful to understand how best to negotiate respiratory muscle training, as the case may be. Now, just like every other training, whether you're training the hamstring, whether you're training the quads, whether you're training whatever it is you decide to train, the biceps and the triceps, there are different principles of exercise training. Now, for the respiratory muscles training, it focuses on these three. Number one is the overload principle. And the overload principle is where we would consider, where we would play a lot of role in considering the fit model. There has been a lot of thought, a lot of conversation or deliberation around adjusting the fit. There's even a research group that has modified the fit, but basically most of us know the fit model for what it is. Now, the overload principle states that in order to progress and improve, we need to put the body under additional stress. If we want success, if we want to strengthen the diaphragm, we need to put it to more stress than it is already getting by doing gentle breathing. Now, a lot of times when we do this, like I said earlier, we are not specifically emphasizing on getting the movement of the diaphragm right. Now, this could be as a result of the position the patient takes. It could also be as a result of the information that the therapist has given the patient. It's a bit of both, really. But basically, we want to give more stress to this patient to be able to actually get the diaphragm to specifically do the things we want them to do. Now, remember the diaphragm, I said earlier, is dome-shaped. So we need to start thinking, how are we going to be able to add some stress to the diaphragm and make it and make it to actually work a little bit harder than it would normally do during gentle breathing. Now, it's important to not overdo it, obviously. And there's a whole lot of conversation around diaphragmatic fatigue, and which is what we emphasize on heavily when we're weaning from mechanical ventilators, especially for our patients on tracheostomy airways. So we're interested in making sure that as physios, we don't overdo things that we shouldn't. So potentially I could come in the morning very motivated to see a trachea tube patient in the ICU and get this patient to sit on the edge of the bed, get them to stand because I am motivated to do this. But I've also forgotten somewhere in the background that this patient has now suddenly been weaned off from a synchronized mode to a bit of independent mode. So what are we going to have? We are going to have a very tired and a very fatigued patient at the end of the day. If this goes further, you are likely to have a patient that will fail the weaning. So it's important for us as a member of the MDT or whoever it is listening to me this evening to always understand what the plan is. Everybody needs to be on the same page. Now, we need to have a conversation around what we are doing today and how what we are doing today is going to be affecting our patient needs to obviously be considered. So principle of overload is important, but make sure you're not overdoing it. The moment you do, you probably take one step forward and 20 backwards. Now, the next principle that I am going to talk about is the reversibility principle, which states that a person will lose their exercise progress once they stop exercising, just like every other person. If you've been going to the gym for the last 1 year and all of a sudden for 1 week or 2 weeks you stop going to the gym, you're going to have a retrograde movement with your physicality and every aspect of you. There is going to be basically a reversibility of all the results that you've achieved over the last 1 year. And there is no hairline as to it. And this simply means that if we have a neuromuscular disease patient in the unit or in critical care, we're trying to get a patient with GBS to do respiratory muscle training, we need to be consistent. The moment we leave 2 sessions out of the picture, we are going to probably come back the next morning and start afresh again. So we haven't made progress just because we haven't been as consistent as we need to be. Now, further down the line, we'll be talking about the need for us to not just think of doing it ourselves. I know this will have peculiarities across different critical care areas or different wards in different hospitals in Nigeria, but we need to understand also that we must not do it all by ourselves. We can teach the patient, we can teach the patient caregivers, both formal and informal caregivers. You can teach the nurses basically to do this, just so you maintain whatever progress you've achieved with your patient. Very important. Now, the next principle for us to talk about is specificity principle. And this talks about in order for us to improve any component of physical fitness, a person must emphasize emphasize on that physical component or that component that we're aiming to progress. Let's take, for example, what we are trying to achieve is to improve the strength of the diaphragm for a patient with GBS. So we need to be specific enough to know that what the end goal is to improve the strength Now, further down the line, we can decide to improve the endurance. That is also achievable. But the first thing for us to think about is that our goals need to be very specific. I know a lot of times we talk about goals being smart, being specific, and sometimes it feels like just national anthem that we never really actually understand or we don't implement formally. But in this particular situation, we need to think about what we are doing for the patient in terms of what are you hoping to achieve. Are you trying to improve the strength? If a spinal cord injury patient comes to you at the level of C4, C5, what are you hoping to do and how are you going to achieve it? Now, this is what the specificity principle is talking about. Now, also, I've talked about respiratory muscle training targeting the improvement of strength and endurance of respiratory muscles. And I will keep saying it. The key muscle for us, whenever we are talking about respiratory muscle training, is the diaphragm. A lot of what we would do when we consider internal intercostals and external intercostals would mostly be passive. And again, we don't need to place emphasis on the accessory muscles of respiration, as the case may be. Now, going forward, what responses do we expect when we do respiratory muscle training? The same response we would get. The diaphragm responds in the same way as your typical skeletal muscle. There will be changes in muscle fiber, and there will be improvement in strength, speed, power, endurance, performance of maximal inspiratory pressure and maximal expiratory pressure. So we're going to talk about maximal inspiratory pressure and maximal expiratory pressure down the line, but it's important for us to keep at the back of the mind that once we are doing respiratory muscle training, that we would expect a change in the muscle fibers, especially the diaphragm, and we also would expect improvements in the strength, speed, power, endurance, performance of MIP and MEP. Now, this will reflect very well on the patient in terms of saturation of oxygen. It will reflect also in terms of respiratory rates. It will reflect on your patient, especially with respect to ETCO2, the end tidal CO2. It will reflect so well if we've done the right kind of activities and we've done it the right way. Okay. Going forward, what signs do we see to tell us that maybe we need to start doing respiratory muscle training for our patients? Now, a lot of times we know neuromuscular diseases, the diagnosis does take a while, and sometimes the signs may not be as specific as you want them to be. Now, there are certain signs as basic as they can be, but it will tell you that there may be a need for us to actually start doing some respiratory muscle training for our patients. If we all of a sudden start to have decreased chest expansion, decreased breath sound, shortness of breath unrelated to any cardiac event, uncoordinated breathing pattern, and then a bit of bradypnea, then decreased tidal volume. These are some of the very basics, but we can look at them as signs for us to actually go, you know what? It's best for us to just start doing some basic respiratory muscle training as early as we can before things will potentially get out of hand. So we are taught basically from our practice to look, listen, and feel. If we're unable to look, if we're unable to listen, if we're unable to feel, it will be difficult to actually make a clinical practitioner. So maybe we can, after this, go back and have a question mark around how we look, how we listen, and how we feel. Very important. Now, going forward, there are key considerations we need to do or we need to make before we consider doing respiratory muscle training. Now, one is correct and appropriate education. If we fail to educate the patient correctly, it will be difficult for the patient to actually engage, and it will be difficult for the patient to actually benefit from the whole point of having respiratory muscle training. And I can tell you with respect to some of the respiratory equipment you will find, baseline, they will cause a bit of anxiety, whether we like it or not. This is the reality of your patient. The patient is wondering, what are you doing to me? What is this again? What is going to happen? And, you're not just going to act like it's nothing. It's definitely something. If you think about it, there are lots of times where people have tried out the patient that hasn't used an NIV before. And all of a sudden, the patient is using the NIV mask for the very first time, using the full-faced NIV mask, and the pressures were so much. And I said to one of the nurses that was mentioning, I don't know why the patient is not tolerating this face mask. I'm like, yeah, do you want to lie down? Let me try it on you. As a matter of fact, I think whatever we are dishing out, we should, find a way to actually have a feel of what it looks like. That way you can be able to understand, best way to actually explain it to your patient. Loads of time in the past, I've had to wear the NIV mats loads of time to do teaching for nurses. I've had to have the cough assist face masks on myself to do trainings and stuff like that. It's the basic of our expectation. We need to think about interferential currents before you do the next interferential current therapy for your patient. Maybe place 2 of those electrodes on you and increase the numbers and see how you feel. How you feel would determine how you go about education for your patient. So think about appropriate education, use simple and clear words that the patient can easily understand, and just stay on track. If you need to reinforce. If possible, what I would normally do is say the first 2 cycles will be for just trial. So just relax, do whatever it is you understand, and we'll adjust it from there. So as much as possible, comfortable room, and make sure that it's as comfortable as it can be and communicate appropriately. I've mentioned earlier the need for us to teach nurses, the need for us to teach formal and informal carers on appropriate techniques. Believe me, patient carers will drive this respiratory muscle training a lot of times more than you do. Remember, even though the patient trusts you, the patient does not really like you that much. In terms of the fact that there's a bit of anxiety that comes with having medical professionals going in and out. Now, if for any reason this is a post-operative procedure or post-operative session, consider optimizing analgesia. I found a lot of times that loads of the breathing exercises that we did, the effectiveness of those breathing exercises were from the fact that we have made adequate considerations for pain. Pain is painful. So basically, make sure that you're thinking about the patient's pain before they get on to doing any form of respiratory muscle training. Now, we're getting somewhere. Always improve functional residual capacity. Always improve functional residual capacity. How do we do this? Get the patient up from bed. Make sure they are sitting upright as much as possible. Make sure the patient is sitting upright so that you're not denying them the ability to actually even get to extend the diaphragm as much as they can or they have capacity to. So make sure that they are sitting upright to do this. There's a comfortable sitting position that helps to do the respiratory muscle training properly. And make sure it's comfortable as much as it can be. All right, now I'm going to the meat of the matter this evening, where we will talk about the maximal inspiratory pressure and also the maximal expiratory pressure, and then what I call the SNP test. The SNP test is still the gold standard for diagnosing unilateral diaphragm paralysis. If for any reason your patient comes in with paralysis of the diaphragm unilaterally, the SNP test is still the gold standard for diagnosing this. Now, one will be wondering, what does the SNP test represent? Let me see if I eventually put this picture. I don't think I did. So, but basically, with the SNP test, we have the respiratory pressure meter. Can you see this slide? The respiratory pressure meter basically, it has an adjustment, or it has it has many parameters on this. Now, this is also one of the things that any company out there could potentially make. But this is quite popular in my practice at the moment. So this is why I'm using it as an example. Now, it has a different attachment for the sniff test. Basically, when you get the patient to sit upright and ask them to squeeze one of their nose and just basically check which one has better airflow when they take big breaths in through their nose. So basically, squeeze one of the nose and try on the other one, compare both sides. Which one feel like it has the best airflow for when the patient takes a big breath? Now, eventually after that happens, the nasal prongs will then go into that nose that has, that side of the nose that has better airflow, and then we would then go ahead to conduct the sniff test. Again, it's almost difficult to explain this without a video, sadly, but we're limited in that sense. But it's important for you to have it at the back of your mind that we can potentially do a sniff test to diagnose unilateral diaphragm paralysis. And then we'll get on to the maximal inspiratory and maximal expiratory pressure. This is what we utilize in the first picture on slide 12. If we do have a nose clip, it will be much effective. And there are also handheld devices, apart from this respiratory pressure meter, that you can find that easily measures or assesses the maximal inspiratory and expiratory pressure. Now, from physiology knowledge, maximal inspiratory pressure is generated during maximal inspiration. Once you are taking enough efforts to take maximal inspiration against a closed system, this is why we think if we have a nose clip on, it will be much beneficial for the patients. And also, the MIPs they are inversely proportional to the lung. They are inversely proportional to the lung volumes, while the MEPs, the maximal expiratory volume, are directly proportional to the lung volume. We'll get into that in a bit. But anytime we have impairment of either inspiratory or expiratory muscles, not only in patients with neuromuscular disease, but also patients that have any form of disease on their lungs, the lung parenchyma or the airways, you would often present with a need to strengthen those specific muscle groups. Although such impairments may be common, oftentimes the recognition of these impairments may be further down the line. A lot of times this can happen further down the line. And it's because the signs and the symptoms are non-specific and they also appear very late. But a keen observing therapist or professional will be able to spot from the go that actually there is quite a bit to actually do with respect to management of this patient. Now, when we go down to the details of the maximal inspiratory pressure and the maximal expiratory pressure, this aids to evaluate respiratory muscle weakness. What we're trying to achieve is to evaluate the weakness of respiratory muscles. Like I've said earlier, that one of them being the diaphragm can easily be evaluated using either the MEP or the MEP, as the case may be. Now, going forward, we can also have the maximal volume ventilation, voluntary ventilation, which is just another measure to actually assess neuromuscular and respiratory symptoms when a patient presents to us. And it's the total volume of air exhaled during 12 seconds, 12 seconds of rapid breathing. And we can also have a predicted, there is a table for predicted maximal voluntary ventilation that you compare what you get from the patient against their predicted age and numbers. And this predicted maximal voluntary ventilation is defined as a forced expiratory volume in 1 second times 30 or 40, as the case may be. So if you think about your forced expiratory volume in 1 second, just part of what we would normally consider in our patients with any form of lung diseases when we're doing spirometry. we also will understand the relationship between FEV1 and then the maximum voluntary ventilation. Now, there is a significant difference between this predicted number and what we can measure of our patient in terms of maximum voluntary ventilation. And this will indicate insufficient neuromuscular reserve. If a patient has a poor neuromuscular reserve, it will be very obvious. You will find a significant difference between the predicted and the measured maximum voluntary ventilation. You can also find an abdominal respiratory mechanics. You can also find inadequate effort if the patient doesn't care, if the patient doesn't really want to do it, and it's just passing time. There's nothing you can do about it. Most of this training will require the motivation of the patient to actually be successful. So if a patient is not interested in whatever it is you're saying to them, it may not really be very effective. So you need to find ways to not just encourage the patient, but also to motivate the patient to go the extra mile and achieve significant results with these procedures. Now, and I've mentioned the sniff test before. Basically, with the sniff test, all we need to do or all we need to think about is diaphragmatic paralysis. If you're thinking about the sniff test, it's basically because you're suspecting that there may be paralysis of the diaphragm. And again, this can happen with our patient with SCI. It can happen with patients that present with phrenic nerve palsy from any source, basically. And you ask the patient to make a quick shot and inspiratory effort through the nose, basically a sniff. I think I feel like I should show this. If you can look, have a look at the camera. So basically, all you need to do is to explain to the patient to take a bit of a sniff with their nose. It's not a proper breathing, so you can get them to do so. And this can be repeated over time, 5 times, stack it up for 5 times to actually get what you're looking out for. So say we found a patient that we want to do a sniff for, or the sniff technique for, which we're going to still discuss further down the line, is we'll ask, go 1, go 2, go 3, go 4, go 5. Basically, you're trying to do some breath stacking for this patient, but you're going to do it through the nasal airway, if that makes sense. Thank you. Right, and the sniff maneuver minimizes the contribution of other respiratory muscles. This completely takes away the impact of the intercostals, both the external and the internal intercostal muscles. So this is why we think it is very, very efficient. So think about all the breathing exercises we've done in the past, over the years, trying to do active cycle of breathing technique. And a lot of times, your patient is doing loads of activity with their scalene muscle, with their sternocleidomastoid, because they are accessory muscles, because you're not paying attention. Most of that is happening from that level. Now, if you haven't ruled out the impact or the input of those muscles into the actual breathing effort, you won't be able to get the results you're looking for. So a weakened hemidiaphragm may have decreased excursion. So while I was taking that sniff, if you looked at the movement of my abdomen, you would find a quick rise and a quick fall. Basically, you want that very synchronized rise and fall, as the case may be. Once I am going, go 1, go 2, go 3, go 4, as the case may be. Now, also, sometimes we may have to consider doing electromyography for the diaphragm and doing nerve testing to the phrenic nerve. And I've seen cases where we had to do ultrasound investigation on the diaphragm to be able to see what's going on in terms of movement. And we can do muscle and nerve biopsies as the case may be. Okay. Now, going forward, give me 1 second. So with this, I've showed a picture of a patient right here on the left completing maximal inspiratory pressure test and maximal respiratory pressure test. And you also have the handheld respiratory pressure meter that can assess maximal inspiratory pressure, maximal expiratory pressure, and also the sniff test. It has a small attachment that runs through it that I haven't captured on this picture. Now, this is your typical inspiratory muscle trainers, right? This is what you will find everywhere. This is what I will use in my practice, ideally, for training inspiratory muscles, right? Now, even within the NHS, as I speak to you now, not every hospital have access to this. So even within so-called civilization, access to this is also limited. My current place of work does not have access to this. But we know that in certain situations, if need be, that we could potentially prove our case and get management to order one or two, just so we could use it for certain patients. So basically, I am saying, even though this is efficient, you may not find it in practice. You may not actually even get to use it at all, but we know it is efficient. Now, this, the one on the right has a bit of inspiratory valve and also a expiratory valve, and they serve as a control. And you can basically increase the strength of your activity, what you're hoping to achieve. So you can start building up your patient from number 1, it's the lowest amount of strength, and you keep going 2 till you get to the highest, which is 6. And it gets real difficult moving the diaphragm. You need to do maximal effort for you to get the diaphragm. But what we found out over time is that for some of our patients attending the clinic that had respiratory muscle training going on, that over time we found them benefiting a lot from this. So basically what we've said to the patients is, if you can afford this, if you think you can, go home, buy it and use. And we found them come back to us with better results in terms of their maximal inspiratory pressure and also their maximal expiratory pressure. Now, this doesn't excuse the fact that there are no other ways for us to do it. If you trained in Nigeria, you will know that adaptation is our second name as physios. Even healthcare professionals generally, we always will adapt to whatever the situation is. So how do we adapt in terms of IMTs, inspiratory muscle training? How do we adapt this? We can use the sniffing technique. First of all, get the patient to, or let me even start from the usual one we know, our favorite go-to. The active cycle of breathing technique can be utilized in such a way that it will eliminate all the efforts of the accessory muscles and focus specifically on the diaphragm. This can be adapted in such a way that it will be helpful not just for training the inspiratory muscles, but also to complete secretion clearance if need be. Now, if your patient has presented with secretion retention, this will be a perfect way for you to actually kill 2 birds with 1 stone. So we can do a couple of breathing control, thoracic expansion, and do the breathing control, and then try the Huff. Now, when we are doing the thoracic expansion, one thing that is important for us to note is, again, eliminating the effects of the accessory muscles. Very important. And stick to trying to improve diaphragmatic movements while you're adapting these IMT techniques. Very important. Now, this is ACBT. You can modify ACBT in different ways, depending on your patient group. There are lots of times where you find the ACBT was designed to help patients, but lots of times we need to be able to modify bits and bobs while using the ACBT to actually get the desired effect. We can also do the sniffing technique. I've mentioned to us before that you can get your patient to start sniffing, start getting them to do maybe 3 at first, So what I would do on my first session is to try to tell them that we'll do only 3 times. We'll do this only 3 times. Basically, relax yourself as much as possible, sitting upright and supporting the both hands on pillows if possible, just so you can get the patient comfortable. And then ask them to sniff. On my count, sniff 1. On my count, 2, sniff 2. On my count, go. So you repeat that for 3 times, get the patient to rest. Repeat that again for 3 times. As they are doing that, you're increasing the number, making it more difficult for them, and then shortening the period of rest in between one sniff and the other. That will get the patient to actually start using their diaphragm rather than the typical breathing control and thoracic expansion we do with ACPT. So very important. So we go from actually sniffing 3 times and then increase to maybe 5, increase to 7, 10, and then decrease the space between sniff 1 and sniff 2 and sniff 3, basically increase it like that. Now, another way I could adapt inspiratory muscle training is by using what we would call the intermittent positive pressure breathing. Now, this is called birds in my climb. It's called bird because the original equipment looks like an ostrich. So how do we utilize this? We often would say utilize pressures between 15 to 30 cm of water, because you don't want to cause any risk of barotrauma or volutrauma, as the case may be. So keep the pressures well under 30. And then instead of just asking the patient to trigger their own breath by themselves, so the emphasis will not be on triggering their own breath in and out, but the emphasis will be on keeping their lungs full. So when they take, again, I will just put on my camera just to maybe see if I demonstrate this, it will make any difference. Yes, so basically you've connected the intermittent positive pressure breathing and you have your circuits all in place. All you need to do is to get your circuit right round, get the mouthpiece on, and you have your mouthpiece right in your mouth, and basically ask the patient to take a big breath and hold it. So take a big breath and ask the patient to just hold it for maybe 2 seconds for a start, and then gradually build up the amount of time they are going to be able to do these big breaths and hold for themselves. If I can borrow 5 minutes from the coordinator, maybe I should have actually set up one of those so that we can actually benefit from that. I'm not sure how much time we have, but the emphasis is we can get the patient to take that nice big breath. Take a big breath and then hold onto at that point. 1, 2, 3, 4. Your metronome, your stop, or your alarm clock will be very important to actually drive home the point. So you're not just going to get them to elevate their diaphragm as much as they can, but you're going to eliminate other aspects of the other accessory muscles that may come into play when you're doing your inspiratory effort. Okay. Because of the want of time, we can use VHI also for mechanically ventilated patients. Lots of smart ways for us to use VHI. The only problem is we cannot use VHI for patients on synchronized mode. If your patient is on SIMV, this patient is ruled out from using the VHI. Also, let's remember that the intermittent positive pressure breathing and the VHI, meanwhile, VHI is basically your ventilator hyperinflation. The green bag that we normally have, the wet socket bag that we have by the bedside of the patients in ICUs, that's your manual hyperinflation. Now, that's exactly the same thing, but it is delivered by the ventilator. So instead of doing it manually, disconnecting the ventilator, you do it with the ventilator, basically synchronizing the breaths of the patient on inspiration and expiration, and then just extending the inspiration time will get you to actually get those nice movements that translate to your inspiratory muscle training very, very nicely. Okay. I'm looking at time. My time is nearly over. Now, this is the chief culprit, incentives spirometry. I know we love the incentives parameter in Nigeria very well, and I cannot be oblivious of that fact. So I'm going to trade very carefully while talking about this, because I may have a few opinions, God, but the truth of the matter is if we're being honest with our practice needs to be evidence-based, and lots of conversation around incentive spirometry is a bit emotional rather than based on facts. There are lots of literatures out there around incentive spirometry, and recently we found evidence supporting the use of incentive spirometry for post-operative patients following upper GI surgery, following thoracic surgeries, yeah, but definitely not on cardiac surgery, and definitely not on any patients following a head and neck surgery, basically. So we have these varieties and they exist for a reason. Now, what we're trying to achieve when we do incentive spirometry is to do first inspiratory technique. And when you do that, it gives the patient a bit of a feedback. I was having a conversation with a therapist in Nigeria. So, and from what he said to me, he said, look, evidence-based is not just a question of what is written on the internet or published in the papers. And I agree with him. There is an aspect that deals with patient's comfort and patient's feedback. So most of the times, the patient feels that this is beneficial. So we can class it as a placebo. But ideally, for most of the time, we found that for a patient that has done incentive spirometry for a course of 7 days, it didn't really make any significant difference when compared to those that didn't do anything at all. So this brings my question: do we still need to be giving it out like chocolate bars and stuff? So let's be careful on that one, yeah. But again, it gets the patient to inspire. But the question is, how much inspiration, how much effort of the diaphragm is utilized? That's the question. But if you do incentive spirometry and mix it up with a bit of expiration exercises, which we're going to talk about now, you will find a lot of benefits for that. And to summarize this session, I'm going to talk about the respiratory muscle training, which is what is very important to us. Now, a lot of times we downplay the importance of expiration because it's a passive process or it's a quiet process, but it's important that obviously sometimes we need to also pay attention to what the internal intercostal muscles are doing. So for us, again, getting the airway open, getting that maximum PEEP that you need for your patients when they've been lying in bed for 4 or 5 days or even longer, is by making sure that you're getting a good amount of PEEP into the lungs and also getting a good amount of expiration out there. Now, there are lots of time where adjustment of the IE ratio, and when I'm talking about the adjustment on the IE ratio, I'm talking about the adjustment on the aspect of expiration, can make a difference between clearing out CO2 as much as we need to and retaining CO2. So we need to think about what's going on with our patients and how we are dealing with situations like this. From what we do in practice currently, we can give a bubble pep. By bubble pep, I will get a bottle of normal saline, the big normal saline bottle that we normally will use to clear secretions. You get a new neat one and put a tube in it, a large hollow tube, maybe one from a nasal specs or oxygen extenders cable. Basically put it on the inside and ask the patient to take a deep breath in and then blow all the way out. When they blow out, it will form a bubble within the bottle. This blowing out process have been found very useful in terms of getting the patient to actually empty out their lungs completely. Now, the other things, I think we've done this a lot of times, even back home, is to get the patient a piece of paper or paper to just blow out, ask them to just blow out and basically empty out their lungs. Very, very important. Now, the other thing we can do, again, if it is safe, I don't know how many hospitals it will be safe in, but if you're in a community or in a secluded environment, is to get a candle and ask the patient to actually blow. You'll find out that a lot of times, most of your patients with neuromuscular diseases will not be able to do that. So basically, anything that helps us to empty out the lungs will be very useful in terms of managing or completing respiratory muscle training for our patients. And on this note, I would like to summarize by saying that the difference between a very successful therapy session and an unsuccessful one will be determined by how much effort we have put into educating the patient doing the right thing. Again, key significance for us will be how then can we exclude the efforts of the accessory muscles? What positions are we going to consider? What level of effort would we use to be able to achieve the results we are looking for? These are some of the questions that we need to ask ourselves going forward in practice. Now, there is no solution fits all. There is no one answer to every question that patients will bring to us. But we must continue to tweak things every day. We must continue to tweak our practice and also ask ourselves the question, why am I doing this? Why am I not doing that? So you need to be able to ask those questions and give yourself the best of answer so that you can achieve the best in terms of patient care for your patients. Thank you very much. And again, it's a pleasure being here today.
Wow. Thank you so much. Please, can we appreciate him with some emojis? Thank you, thank you. Please, let's appreciate our presenter with any emoji that will, show how you feel. I really want to appreciate Dr. Uche Nwoke Chigozie. This your presentation is loaded, as in, it's like we should start from the beginning. I want to thank all the participants, but let's take questions first before I say what I have in mind. Please, if you have questions, please raise your hand so that we can take the questions first. Okay. Does anybody have any questions to say? You can unmute yourself and ask your question. If not, I will start with my own because I have some questions to ask. Okay. Some people raised their hands. Please, can you unmute yourself and speak? I can see Emmanuel raised hand.
Hello, good evening.
Good evening.
Thank you very much for the presentation. It was very educative. My question is it's not actually a question, just a demonstration of the sleep technique. I think I missed that aspect. I just want to see how he demonstrated the sleep technique. Thank you.
Okay, thank you. Do we take all the questions or should I just answer this quickly?
Okay, maybe you can take all the questions. Then, Anthony, can you ask your question? Please, if you are not speaking, please mute yourself so that we can have a one house. Anthony, go ahead. Anthony, Ifan, you raised your hand. If Anthony is not ready, can Chidozie ask his question? Okay, they are not ready. Samuel, can you ask your question?
All right. Good evening, sir. Thank you very much for the presentation. It was a really good one. I have a question concerning the aspect of asking, like making sure our patients don't use accessory muscles in breathing when, especially when we're focusing on improving the diaphragm. So the problem I have most of the time is trying to explain to them how they should do that. So I just wanted to ask, from your own practice, what works best for you, especially when trying to explain to the patient how to not use accessory muscles? Like, how do you tell them to do it? Thank you very much, sir.
Okay. Omotunde, are you there? Or Chidozie, either of you can ask your question.
Thank you so much for the presentation. My question is they say you can use sandbag to strengthen the diaphragm. Does it really work in strengthening the diaphragm? Like, does it isolate the diaphragm itself?
All right, thank you. All right. You can put your hand down now, please. Anthony, are you there? Okay, Anthony's hand is down. So let's check. Please, Dr. Chomoke, wait. Let's check if we have other questions. Whether someone wrote in. Let's see if there's any question on the chat box. Okay. Okay, you can take the questions now. Maybe others can ask. If there's no other question, I can now ask my own, and we take the final comment. Thank you very much.
Okay, thank you very much, everyone, for the question. It's interesting. I'll start from the last one. Sandbag for strengthening the diaphragm. Honestly, I heard it once in passing, but I didn't think it was serious until I heard it this night again. I haven't tried that in practice before. I would be interested in seeing if there is a chance that works. I will also be open for that feedback, really. I haven't used anything like that in practice, but I've heard it in passing once before, and it will be interesting to see if there is any chance that actually works. Because if we're looking at diaphragmatic strengthening, what we're thinking is to how do we extend the diaphragm a bit more so that it doesn't flatten out or deepen, as the case may be. But yeah, the jury is out. I'll probably look into that and see if there's any justice or any bits of truth to that, and maybe I could send an email or something, but I haven't tried that before. Now, for accessory muscles, how best do you explain this? Again, that's a very interesting question, to be honest. There is no easy way out of this. There is nothing I will say here that will make it easier tomorrow. The one thing I will say to you is, because certain times, if you've done certain things over and over, it kind of gives you the advantage to be able to explain it better. From my point of view, what I think works is being able to show a video explaining what happens. A lot of times the feedback we give is great, but the patient is for different reasons do not give it the maximal attention that you may want to think they can. So please, as much as possible, find a video on the internet, on YouTube, and get the patient to see, and then explain what you want to do in case you want to make an adjustment to this. Explain what you want to do. Basically, I will always say this: get the patient to sit upright in a sitting position and basically well supported, and do stuff from there. If it's not at a position where the functional residual capacity is at optimum, you would find a lot of concerns with respect to isolating the accessory muscles. Sometimes you may need to have prompts to just relax and also just tap on those SCM every now and then. So there is no easy way out, but try and find a video. Sometimes it's the first step to getting the right results. I found it quite useful. Now, for demonstration of the sniff technique, again, patient is sitting upright and patient is comfortable, and patient understand what we want to do. My instructions are very clear and simple. We are going to do some sniffs. I want you to do the sniffs with me on my count. I'm going to go in 3, 2, 1. Then I will go for sniff 1, sniff 2, sniff 3, sniff 4, sniff 5. With this, you're able to just directly get what you're looking for in terms of strengthening of the diaphragm. Now, this would face its own challenge because at first the patient will struggle with getting this done. It won't be as easy and as straightforward as I make it look. It will be a bit more of a challenge. Ooh. It will be a bit more of a challenge to actually utilize that the first time, but giving more practice, giving more different trials, you will get the results down the line. Again, remember, just like every day, for those of us that go to the gym, you don't get the results on the first trial. You don't all of a sudden start to see your P major, your P minor, or your biceps or your triceps growing bigger and bulkier because you went to the gym today. No, it's a process. So you need to remember that when you're trying to strengthen the respiratory muscles also, your first session may not get you the information or the necessary feedback you're looking for, but driving it in a bit more consistently, clear with your points, will make it a lot easier going forward. Now, there is an interesting question from Yakubu on YouTube. Respiratory muscle training, is it safe to turn the incentive spirometer upside down and ask the patient to blow? Ooh. I haven't seen this before already. I don't know why we want to think about turning the incentive spirometer upside down though. The whole point of the incentive spirometer is to be able to give feedback. So if we are not giving that feedback from the meter readings on the incentive spirometry, I think the whole point to that as a respiratory adjunct is defeated. So please, let's stick to keeping it up as designed by the manufacturers. That would make a lot of sense, please. Thank you very much. Ngozi Ekwueme on YouTube.
Okay.
Yeah, sorry. Do you want to say something, Mrs. Mosu?
No.
Okay.
Just laughing. No, I sang.
Okay. For the sniff test, can it be likened to the glossopharyngeal?
I wanted to, but
I can't hear you.
take Ngosi's question so I can take it.
Okay. Can it be likened to glossopharyngeal breathing as in spinal muscular atrophy as treatment approach? There are two, the glossopharyngeal breathing and the sniffing technique, they are two different things. It brings almost the same reaction, but there are two different treatment approaches, please. Thank you. Glossopharyngeal breathing is quite different. It brings almost similar reaction in terms of how the patient presents while or once they do it. But they are two different stuff. Yeah, thank you.
Okay, thank you so much. So much. I appreciate your presentation is loaded. And as our culture in cardio education group, we have not ended with you because I think there's need to step these things down a little more. Like I'm interested in the MIP and MEP measurements. I know that there was a time we had something like that in UNTH, but we don't have it anymore. And it would be nice if you can just make short videos of how these things are used. I know we can go to YouTube and see them, but it would be nice to see someone doing it practical, real life. That is one. Then other techniques you talked about, I'll be so glad to, maybe if it's possible to see you do it on patient, because I know the one of hyperinflation, I've not used I've not used ventilator to do that before. I've not.
You've not used ventilator to do what?
It's nice to know how that is done, because what we usually do, the manual hyperinflation, we just use we have ambo bag that has meter gauge.
Yeah.
So we can connect to oxygen and do the manual hyperinflation.
So
but
you
have
haven't
not had
used
experience of using it on ventilator.
As in you haven't used it on a ventilated patient?
On a ventilated patient?
Yes.
That's what I'm saying. I've not had the experience of connecting the bag to the ventilator. Okay. So we can disconnect, connect to oxygen and do that manual hyperinflation for some time and connect back. So I'm glad to know that this we can connect to vents and do it that way. The truth of the matter is that your presentation needs a lot of practical sessions for it to go down. For us to really digest it. So I'll be calling on you throughout this week to show us one or two. Then when you talked about incentive spirometer, I started laughing because I know that I'm a very big corporate and I use it a lot. Even during open heart patient, you know,
Yeah.
we're using it for patients. And now you're telling us that we should be careful. So we still need to go down, really well on incentive spirometer, because the truth is that it's good to do evidence-based.
Yeah.
And just like that person told you, sometimes evidence-based may not be only what you have seen on the paper. Do you know? If I
Yeah.
give a
Yeah.
patient incentive and I notice that the patient is struggling, I can tilt it. I can bend it a little. And the essence is that I want to remove gravity and teach the patient first and get this patient to understand how to do this without getting the accessory muscles involved. If I notice that my patient has understood me, I will now keep it erect and patient will start. So there are things we still do around patients that we cannot say is evidence-based yet, but they work. So you just want to keep putting all these things down. And maybe one day you put them together and put it out in paper. So I really want to appreciate this presentation, because this is the real deal for every physiotherapist. If we don't get how to train inspiratory and expiratory muscle, we have not gotten it. Because once you get it, that is how you can see a patient get off oxygen. You see your patient get off ventilator. Because some patient can become ventilator dependent, oxygen dependent, and everybody is waiting on the physiotherapist to do that magic so that the respiratory muscles can take over. So if we don't learn how to do this, we will not be very happy, practicing. So please, Dr. Uche, you will really, give us the opportunity of calling on you throughout this week so that we can digest this topic.
I will
Please.
try and see. I will try and see what I can lay my hands on in terms of videos and stuff. But once I find anything useful, I will let you know. Thank you very
In
much.
fact, you are going to help us buy. You are going to send that MIP meter to us now.
That one is not expensive. I can send it. Don't worry.
Please, so that we can start using it. Thank you so much. Thank you so much. I appreciate. Please, can we show him some love with emojis? In fact, this presentation is something else, but I'm not surprised. I'm not surprised because you have really been a cerebral person. So thank you for being there for us. On this note, I want to thank every one of us for participating. Please stay tuned to the cardio education group, because we keep asking questions, keep providing the answers. The presenter will be there to also give his beats until we are sure, at least, that all of us are comfortable and we have learned one or two things that will impact positively on our patients. We have a YouTube channel for cardio education group, so that we can go there, subscribe, and join the YouTube anytime we're having monthly classes. The next monthly class will be in November. We're going to publish the dates and we'll be looking at X-ray of the lung and the heart. And we're privileged to have the head of department of radiology coming to speak to us. So please stay tuned and thank you for participating. I believe that in sharing knowledge, we're going to become better cardiopulmonary physiotherapy and impact our practice. Thank you so much and see you next month. But stay tuned to the cardio group. God bless you all. Good night. You people should show me love too. I need the emoji. Thank you. Thank you. Thank you. Good night. You can unmute yourself and say good night to each other. Good night. Good night. Good night.
Night.
Nice. Wonderful
Good
Thank you so
night.
much.
Good night, Mr. Chinwe. Bye.
Bye.
Good
Bye.
Good
Thank you
night.
so much.
Good night.
Emila, is that you?
Good night.
Good night.
Night, night.
Good night. Mrs. Moss, good night.
Good night. Good night. See you.
See you.